Good afternoon, friends, and thanks organizer for giving me an opportunity to be here to discuss first line therapy for ROS rearrangement and NSCLC. And as we know, the ROS rearrangement found only in very rarely in the patients of NSCLC, about 1 to 2%, and only 10,000 to 15,000 patients in the world have harboring this ROS rearrangement. Patients, and we know this is the very rarely this overlap with the other mutations, and this is found in the unique subset of the patients, like patients are younger age, most or never smokers, having predominantly adenocarcinoma histology, and about 60% have extra thoracic metastasis at the baseline, and about 20 to 30% may have asymptomatic brain metastasis. That's why it's very important to do a brain metastasis screening before starting any treatment. So ROS1 is basically located on chromosome 6q22 and have multiple fusion patterns, but most common fusion pattern is the CD74. So coming to the background history of development of ROS rearrangement treatment, in 2017 this was diagnosed in NSCLC, and in 2014 first drug crizotinib has shown some clinical efficacy, and they have published the data. And in 2016 on this basis crizotinib was approved by FDA for the first line treatment in the NSCLC. In 2017 another one drug have also shown the efficacy in the ROS rearrangement patients, certinib, and depending on the death trial, and this was included in the NCCN guideline but not approved by FDA. In 2019 also the lorlatinib is also shown clinical efficacy in crizotinib naive and crizotinib treated patients, but somehow it did not get approval, still get an approval by FDA or included in NCCN guideline in the first line recommendation. But yes, in the NCCN guideline they have included in the second line therapy after progression on the crizotinib. And one more another drug, entrectinib, we also gain our FDA approval in 2020 depending on the study, and in 2020, and recently one more drug rapotinib is approved in 2023 in November for the treatment of first line in the metastatic ROS positive NSCLC. So this is Profile 101 was the landmark trial on which which was published in 2040 by Shah et al. And on that trial it got approval from FDA, and they have also published updated data, 5-year survival updated data in 2019, and comparing to the initial study, overall response and progression is less or more same after reporting the 5-year survival in 53 evaluable patients, but somehow we did the duration, increase the duration of time, duration of response is improved 24 compared to 17 in initial study, and yes, so overall survival is also reported 51, which was not reported in the initial study. So it is very important. It was very important study that in the chemotherapy arm only progression-free survival is only 5 to 7 months, where in this study it is reported 51-month overall survival in these patients. So the crizotinib is a well-tolerated drug in this and have not shown any grade 4 or grade 5 serious adverse event in this study, and other effects side effects are grade 1, grade 2, and usually they are gastrointestinal, like nausea, vomiting, and having very asymptomatic hypophosphatemia was seen in this study. So it is well tolerated and having without major side effect in grade 3, grade 4. But unfortunately crizotinib have limited CNS presentation, so that's why nearly half of the patient develops brain metastasis who are on the crizotinib arm, drug, and that's why it's very important to regular follow up this patient with the brain mapping and brain screening, the patient who may develop asymptomatic brain metastasis who are on the crizotinib arm. So resistance to crizotinib developed by two ways. One is the on-target mutation, resistance, which is acquired, and secondary to ROS mutation, especially ROS G2032R, which occur in 20 to 35% patients. Another mutation like G2030, occur in 1 to 2% patients, and unfortunately, certinib or entrectinib don't work on this mutation. And another mutation is off-driver mutation, which occur in 60% patients, and that can be because of alternative bypassing signaling pathway that drive resistance as the secondary pathway, and amplification of VEGFR, ALK or MET amplifications can happen in this off-driver mutations, and there is no more effective drugs available for these off-driver mutation. Some people have tried double TKI or chemotherapy plus TKI in this patient. This is very good data. Just my previous speaker have also shown the data from India, and have shown that there is a little bit increase incidence of RET mutation in our India, and also this publication published from our India by Kumar Prabhas sir, and have also shown there is a little bit high incidence of ROS rearrangement mutation in the Indian population, and also they have reconfirmed the efficacy of crizotinib in this patient, Indian population. But in this study, they have shown that there is only one single prognostic factor is the poor performance status of a person, and if the patient have a poor performance status, then they have very bad prognostic factor, bad prognosis. Next drug, certinib have also show the clinical efficacy in the ROS rearrangement, and active against the crizotinib naive and previously treated patient. In this certinib have also shown the clinical activity, meaningful activity in the brain metastasis, and it also crossed the blood-brain barrier. That's why it's used, recommended by NCCN guideline in first-line therapy, but still not FDA approved for first-line therapy. So certinib, NCCN guideline recommend certinib as first-line therapy on basis of this open-label multicentric phase second study of certinib in patient with NSCLC harboring ROS1 regimen, published by Surmin Lin, which have shown that there is overall response rate of 62% in the evaluable 32 patients, and median progression survival is 9.3 months in all patients, and 19.3% crizotinib patient, which is less or more equivalent to crizotinib treated patient. So have shown very good equivalent efficacy. And duration of response was 21 months, same as crizotinib, but the somehow MOS is 24 months. Another is entrectinib in ROS fusion post-operation, and Durian Alexander on the basis of Durian Alexander publication of integrated analysis of data of 3 trials, ALCA, STARK2, FDA approved this drug in the ROS1 rearrangement, and they have shown that the overall response rate is 77%, 53%, progression survival is 90%, and DOR is 24%. And very importantly, intracranial response rate was seen in 55% patient, and progression-free in brain mets at 13%. So that's why it's a very good CNS penetration, and is very potent against the ROS1 multikinase, because this is multikinase TKI. It also inhibits the TRK, B and C protein in the specific present in the brain. So that's why they have neurotoxicity, more side effect, and dizziness, headache, lightheaded issue with this, and photoperception. And this TRK is so next drug is also shown efficacy is the lorlatinib, and one clinical study of 47 patients, they have shown that crizotinib naive is response was 61%, and in crizotinib treated patient 26%. Overall response in brain mets is shown in 70%, but still they did not get approval as a first line treatment by the FDA or by the NCCN guideline. And again, this is multikinase TKI and inhibit the BRC and NRK B and C protein in the brain, specific in brain. So that's why these have also neurocognitive and neurotoxicity more other than other drug. But unique TKI side effect is the hyperlipidemia, which is unique to this lorlatinib. So coming to the next approved FDA approved repotrectinib, which is also multi-kinase TKI and very potent against ROS, specifically designed to overcome the gatekeeper and solvent frontline resistant mutation 20 to 32R, which is 20 to 30% occur after crizotinib treatment and this repotrectinib got approval for FDA approval by the Trident 1 trial, where they have shown their very good result, and 88% patients are responding very well, and still there is no reported overall survival and duration, but somehow overall response seen in approximately 33% patients who were treated by crizotinib. And most adverse one again because of multi-TKI inhibitor and inhibit the NRK BC protein in the brain. So that's why neurotoxicity is the main concern for this treatment too. But it is a very good efficacy on the G2033 mutation. Another drug which is knocking the door of this ROS1 rearrangement is taletrectinib. Just this data was updated and presented in the ESCO recently, and as a phase 2 trial by Answer, and this have shown very durable response rate in TKI naive and TKI crizotinib pretreated, and more than 90% response was seen, but overall OS and progression is still not reported, but somehow this is very I can say this may be the blockbuster drug which is coming in the future and have very good activity in against resistant mutation, including the G2032, and have very less side effect neurotoxicity, even being a multi-kinase TKI. So one important point is we should not forget the chemotherapy in the ROS positive cancer patients, because this is also one can be one first option in this patient who cannot bear the cost of this TKI or cannot have this access to TKI because of their any personal reason. So even in ROS positive patients, the progression-free survival is less than 7 months, but we should offer this treatment also upfront in patients and have. And pemetrexed is very good drug compared to any other chemotherapy because of expression of thymate, low level of expression of thymate synthesis in this ROS1 NSCLC. If we compare the if we compare the efficacy of FDA approved and NCCN guideline included recommendation, then the overall response in all TKIs is less or more same compared to cytotoxic drug, which is less, and PFS is almost same except repotrectinib, which is almost double than other available TKIs, and cost is all first two are not available in India, but crizotinib cost around 90,000 compared to serotinib, which is almost double, and cytotoxic can be free of cost in government institute and also can be of 20 to 30,000 in the private hospitals. And if we see the side effect, the first and second repotrectinib have a neurological more side effect. Crizotinib is well tolerated with mild 1 to 2 side effect of GI symptoms, but serotinib is having more side effect and is little bit toxic than crizotinib, and cytotoxic we all know about the myelosuppression and toxicity. So if I have to choose between choose the first line treatment in the ROS rearrangement, then I will take account of 4 main points. One is the CNS metastasis at the first time on the diagnosis, and second one is the efficacy and effectiveness of the treatment in this patient, and third one is the toxicity profile of TKI itself with comorbidity of the patients, and of course first one is the affordability and cost of the patients. Thank you very much. Thank you.